My topic is the multimodal approach in Pectus excavatum. If you classify the painting, we may say that the artist Christian Schad have also dealt with the topic appropriately. You can see the median funnel chest and the protruding costal arches. Here you see the spectrum of thoracic deformities, sternal defects, Pectus excavatum, carinatum, the mixed variants, and also others. Today I am presenting the topic of Pectus excavatus treatment, and for this I have selected results from 346 patients operated with adapted and extended techniques by myself. The sagittal MRI shows the sunken corpus sterni with remarkable bone nuclei until the growth is finished. Here you can see the development of Pectus excavatum graphically animated, mostly taking place during the puberty growth spurt. As a rule, the deepest depression is found on the right lateral side of the sternum, and this at an older age. The sternum is also rotated on one side in the distal selection of its corpus. The further thoracic development progresses, the more the lateral bony rib sections are inclined inward. You see here. Additionally, you see the heavy rotation of the middle and distal part of the sternum. The heavy rotation of the middle and the distal part of the sternum. Here you can see the MRIs, how the funnel deepens significantly within 2 years during the body development. On this slide, there are presented the different symptoms and morphological findings in patients with Pectus excavatum. Special importance is seen in the lung and cardiac findings, the reduced vital capacity, the ventilatory deficits, the mediastinal shift, the reduced ejection fraction, and cardiac arrhythmias. But we should not forget the stressing mental dimension, reduced self-esteem, depressions, reduced quality of life, self-aggression, panic attacks, and suicidal statements. Internationally, the indication for surgical correction is based on a Haller index greater than 3.2. The Haller index is calculated. We take the longest transverse diameter and divide it through the shortest sagittal distance. Now we turn it first to the cardiac problems. You have the mediastinal shift, you have a compression of the heart, you have a restricted right heart filling, we see an exercise cardiac output limitation, and the compensation efforts lead to tachycardia, high heart frequency. If we look here, and it is shown in the MRI, the right ventricle is in people with Pectus excavatum in a tubular shape. This is a normal shape. This is the tubular shape. And the excursion of the right ventricle is progressively limited. Increased cardiac output can then be achieved primarily by increasing the heart rate. The altered geometry of the thorax and the diaphragm leads to altered breathing mechanics, whereby the lungs have difficulties to be fully expanded. The diaphragm seems to be too large. The result is a load-dependent shortness of breath. Here you see the normal size of the diaphragm. Here you see the altered design and the altered shape of the diaphragm, and also the problems in expanding the whole lung tissue. In the red background above, you can see the historical course of the surgical therapy of the fundal chest, starting with Mark Ravitch, who introduces cartilage resection and sternotomy, followed by Rehbein, who introduced symmetrical metal struts. Welsh and Leonard correctly indicated that the perichondrium must be preserved if you resect the cartilage of the ribs. Donald Nuss introduces the minimal invasive pectus repair with bars without additional surgery on the chest deformity. In usually older people with deep deformities and stiffer thorax, I introduced a new designed one-piece metal implant and additive surgical techniques to increase the flexibility of the chest and the sternum. If we look below, in the blue background, there is shown the historical course of conservative therapeutic measures of the funnel chest treatment. Sauerbruch introduced a technical system that lifts the sternum like a crane when the patient is lying horizontally in his bed. Globe introduced a vacuum bell to flatten the funnel by suction. He found that for different thoracic deformities, there must be different shaped vacuum suction bells that need to be individually fitted. This was my step in the development. Both forms of therapies were used separated by the group of conservative and the group of surgical practitioners. The innovation is now the combined application from both therapeutic approaches. In the first step, conservative, and mostly in the second step, also surgical, also operative. Here you can see the principle of the vacuum bell treatment. The bell has to be positioned with the margins directly on the protruding edges of the funnel. In cases showing special shapes, asymmetric shapes, for example, an asymmetric narrow funnel, the available shape of the bell is not suitable. As you can see here, it is too large and leads, due to an elevation, also to a formation of a carinatum deformity. It is a matter of extending a suction on the lowered and a pressure on the protruding parts of the chest. Therefore, for effectiveness, the vacuum pressure bells, it requires additional fitting shapes, such like a canoe shape, as you can see here on the right, and perhaps also an inverted Y shape of the bell in a patient in the picture below right. So you have give on these protrusions a pressure, and you have suck here in the area in the middle. Therefore, you need an inversed Y-shaped bell design. This is an overview of the conservative and the operative treatment options. you see how the depth of the tunnel is measured. It's like this. It's very easy. Funnel development begins at different times in childhood, but is particularly pronounced during the pubertal growth spurt. So the tunnel becomes deeper. This is when the funnel has to be started to put it into a conservative medical treatment. When the conservative treatment is started, the vacuum bell must be adjusted and used daily for at least 2 hours. The funnel flattens, so you see here, the saw-like curve, here the funnel flattens and deepens afterwards again because of the tissue's memory. The situation improves successively in the next time and in the next weeks of the therapeutic measures. You see a flattening that may also stay permanently. Usually the success remains stable after a plateau of about 3 months. Further flattening cannot guarantee it. If the conservative therapy is stopped, the funnel shrinks again into a deeper position. The conservative measures alleviate and shorten postoperative pain periods. In the upper right corner, you can see a limited success of the conservative therapy in a publication. Many patients may be not completely satisfied with that result and have complaints. Therefore, the conservative therapy may be followed by a surgical correction which optimizes the shape using 1 or 2 support implants. Now I come to the technique of the minimal invasive pectus repair. Here you see the principles of this modern funnel chest correction described by Donald Nuss in the so-called minimal invasive pectus repair. In blue, you see the individually shaped implant that is brought via the precisely prepared implant path into its final position by a 180-degree rotation. In the preparation way, the intercostal spaces have to be passed inside the funnel ring. The location is correct here, and it is correct here. Inside, and these cyan marked lines, they show the funnel edge, and inside the funnel edge, you have to pass the intercostal space. This is the turned 100-degree rotated and positioned implant elevating the sternum. Here you have the X-ray preoperatively, and here you have the X-ray postoperatively. You see the implant and the straight sternum. Explantation is possible with nearly no risk of recurrence after 4 years. Now to the best age of correction. One possibility is the correction before 8, because recurrence is decreased because of the lung growth. The second possibility, which is used by most of the patients, is around 15 until the age of 18. Afterwards, we have a more rigid thorax and also more asymmetrical types. Here you see such a young patient, and here the older patients with 1 or 2 implants. Here is the age distribution of these 346 patients, and you see that already between 14 and 16, around 15, we have the highest incidence of operations, and the mean age of all the patients is 18.2. Females are in about 20% affected, males are in about 80% affected. If you have one implant, usually it's a younger patient. If you have two implants, it's usually an older patient. Some technical aspects. You see here the individual C-shaped implant already in the position to be turned. The sternum must be lifted to reduce the pressure on the metal implant. Traction on both instruments during rotation for the positioning the ends in the prepared muscle pouch. And here you see under the mobilized edge of the musculus latissimus dorsi, and also in the central part of the implant bed, it's the implant, the metal, the steel implant is under the musculus pectoralis major. So it's the musculus latissimus dorsi and the musculus pectoralis major, which are very important and are the muscle cuff around the pectus implant. Here you see the original multi-piece implant that still is used today in some places. It consists of 3 metal parts pushed into each other. These are the 3 metal parts. And this, therefore, the end of the implant plate must be straight so that the stabilizer, this is the stabilizer or the 2 stabilizers, can be pushed on easily. A sometimes necessary exact adjustment here is exact adjustment to the body by bending the end into a fitting position is unfortunately not always possible. Stabilizers can slip and leave their position. Wire fixation, as you see it here, can break and lead to pneumothorax. The stabilizer end can slip under the upper rib and cause irritation to the intercostal vascular nerve bundle. Metal-to-metal contact, as it's here, seen here or here, should be avoided. Metal abrasion occurs as a result of metal parts being pushed on and perhaps moving during breathing. These multiple piece models should not be used longer, and even cross implant plates, they have a risk of significant metal abrasion. Excuse me. You see here the metal debris in the lymphatic system, the tissues and the black abrasion from the implant in the lymphatic system. Here you see the composition of the implant. So you have the iron, you have the nickel, you have the chrome. The one-piece implant with a permanently integrated stabilizer flag avoids the just mentioned complications. It can be adjusted to the body on both sides until the end. 2 implants can be used on top of each other for older persons and stiff thorax. You get, if you are waiting for the implant, you get this implant in a straight fashion. You have to shape it individually just during the operation. This diagram shows the number of implant lengths used in inches. So we are using 13 until 16-inch long implants in most of the patients. This is a typical pectus excavatum in a flexible thorax of a lady. By minimally invasive pectus repair, it could be corrected with good result in one operation. Now to the extended minimally invasive pectus repair. It needs sometimes additional operative techniques. Especially there are situations in which you have also to combine these methods. Especially in highly developed Pectus excavatum for more than 4 centimeters, in rigid thorax in older patients, in curved sternum, in mixed forms, carinatum and excavatum, in asymmetric forms, and in bulging cartilaginous costal arches. So the first method is the sternum osteotomy, partly performed horizontal or oblique. On the left side, you see such a horizontal osteotomy of the sternum, and it is at the highest point of the flexure, and then you can make the sternum straight. Or the oblique partial sternotomy, especially in rotated sternums, to correct the rotation. We come to the next step, the rib chondrotomy or osteotomy. You see the thoracoscopically performed partial rib chondrotomies to get more flexibility. Here is the scope, and here is the device for this slit chondrotomy. Here you see these slit chondrotomies. They make the rib cage more flexible. The next step is to mobilize the anterior mediastinum. Sometimes there are strong fibrotic adhesions which have to be divided. Especially here, they have to be thoracoscopically performed chondrotomies to make it more flexible. The edge of this sternum of the funnel reaches the spine. It's a severe malformation. And here the rib osteotomy sites are marked by cyan lines. So you have the rib ends are inwarded, decreased from the surface, inwarded, and here there has to be done a osteotomy of the ribs. This is before the operation, and this is after the operation. Now the partal rib resections. The pectus excavatum is surgically already corrected with partal sternotomy and 2 sternal lifting metal bars, but we realize atypically elongated cartilaginous rib portion of the inferior costal arch. In these cases, the protruding rib portions must be peeled from the perichondrium and resected. A suitable cartilage regenerate forms in the tightened perichondrium tubes within about 2 months. Here, a total correction was performed via 6 accesses, 1, 2, 3, 4, 5, 6 accesses in one operation. Correction of the funnel chest and also correcting the protruding ribs, modulation of the ribs. This was the final result after visiting a fitness club permanently. Now I will introduce you to the Corino-Silverman syndrome. With a very short sternum, there is a carinatum and also an excavatum area. So you need a rib cartilage resection, a sternotomy, and a pectus bar insertion. The elongated cartilage in that area, there are only two or sometimes 3 ribs affected. The elongated cartilage is peeled from the perichondrium. The perichondrium is tightened so that the suitable cartilage regenerate is formed. The funnel is corrected with a single bar lifting the sternum. And that's, for example, the result. Now about the distribution and frequency of the operational measures within the extended minimal invasive pectus repair. On the P chart, you see most frequent measures labeled in red bold text, nämlich rib chondrotomy, sternotomy, and sterno and rib chondrotomy. The measurement table or the measurements can be also calculated with the vertebral index or the Haller index. The vertebral index you see here. This is the physiological range of a normal vertebral index. And this is the value before the operation in the minimal invasive pectus repair, and also in the patients which had extended minimal invasive pectus repair. And you see, due to the operation, the vertebral index post-operatively reaches a normal range. And also if you have the steel implants explanted after the explant, here in a duration 3.6 years after the explantation, the thorax stays in the normal achieved fashion. The same is also demonstrable with the Haller index. It should be below 3.2. You see the pathologic Haller index, which is decreased to the normal range after the operation. And this is a very nice result. Here you can see the assessment of the treatment success by the patient. Most of the patients are happy and they classify it as very good. Also after the pectus bar removal, 15% or 12% classify the situation as good, then as satisfactory. And here we have in 2% the problem, the overcorrection. We produce the pectus carinatum. And here also the situation that recurrence can occur. Here, this patient said the result was good. In this man, there was a silicone cushion subcutaneous implanted. We removed the silicone cushion and lifted the sternum with 2 steel implants. Here we have a satisfactory result. They said, yes, it's satisfactory. And here I show you the overcorrection. You see here it's cosmetically not nice. The bar and the sternum, which is above the level of the thorax. And in this case, a man or a boy who received the first correction in an age which is not a very excellent or a fitting time, with 11 years. Then we had to explant the bars with 14, and with 16 he had again the recurrence. So we had to do again a correction of the deformities, implanting the bars in the age of 16. And then we have also very good results. This is before the operation, this is after the operation, this is another patient. If we come to the complications, and you see that the complications are below 2.4%. That can be classified here as low in this collective of 346 patients. Implant displacement resulted in one patient many years ago, where absorbable suture material was used for the muscle pouches and fixation of the really, you see the design, the really old historic bar. The other problem may be tissue necrosis is found at the high pressure zones in the rib crossing implant area. They are located where the implant crosses and rests on the rib. There are 2 such zones in patients with 1 implant. In cases of 2 implants, there are 4 zones which additionally divides the local pressure load on the tissues on 4 different locations. Additionally, I have to say that the partial sternotomy, which was not done in this case, also reduces the pressure and was unfortunately avoided, as I said before. Post-operatively, the following aspects must be considered for further treatment. Adequate analgesics, respiratory therapy, that means inhale deeply, hold your breath, exhale slowly, early mobilization, correction of the posture, improvement of the posture, improve body perception, stretch the shortened muscles, especially the pectoralis muscle, training the trunk muscles after 8 weeks. And that means the back muscles, the upper body muscles, and the abdominal muscles. And all sports are possible 2 months after the operation. Swimming, handball games, fitness center, climbing, but parachuting also. A lot of different sports, all sports are possible after 2 months. And so modern successful funnel chest treatment presents multimodality with a conservative and a surgical segment. So you have on one side the conservative measures with the vacuum pressure bell, the muscle strengthening, the upper body training, and you have the operative chest repair, who leads really to enlargement of the thoracic cavity. It helps raising the depressed sternum completely and decompresses lung and heart. Thank you for your attention.